So where we left off last week was with a difference in angulation for knees. And just to kind of review that, what we're talking about there is the distance between the anterior superior iliac spine, which is a little bone that sticks out the front of the pelvis, from that distance to the tabletop. And I told you to remember 19 through 24, and if it's below 19, then you angle basically 5 degrees caudad, 3 to 5 degrees caudad. But if it's above 24, you do the exact same thing, except you're angling 3 to 5 degrees cephalad. So 19, 24, you're going to be perpendicular. You're not going to have any kind of angle on it whatsoever. So you're going to be looking for evidence of proper collimation. You want the knee fully extended if the patient will allow it. We're not going to have views like what we had in the elbow. If the patient can't straighten their knee out, then they just can't straighten the knee out. We want to see it without rotation, and what we're going to be looking for there is moral condyles being symmetric on both sides. And you're going to have a little bit of superimposition between the proximal end of the tibia and fibula. So if you've got an increase or decrease of superimposition beyond about what you're seeing here, then you've got some rotation. If it's externally rotated, it's going to increase the superimposition. If it's internally rotated, it's going to decrease the superimposition. You may have a tendency to think, well, why don't I just look at the kneecap? And a kneecap in healthy anatomy should be a pretty good indicator. Its location should be fairly well centered on the distal portion of the femur. But there are a lot of conditions where the kneecap just doesn't track properly, meaning that it doesn't, ascend and descend properly when you bend and straighten your knee. So in some patients, it's just going to be off to the side. You can have an unrotated knee, but the kneecap is off to the side. So it's not always a good indicator of whether or not you've got an unrotated knee. So open femorotibial joint with the interspace of equal width. And again, sometimes because knees wear out, one of the more common anatomies that we have to have a total replacement on is the knee. Again, sometimes your patients younger in life, they were walking straight, and now all of a sudden they're either bow-legged or knock-kneed because their knees just wore out. And there is a term for each one of those. The angulation of the knee can be either in what they call valgus or varus. I'm not real sure which one is which, but that's basically the scientific name for knock-kneed or bow-legged. So if you hear that referred to, if somebody's taking a look at a weight-bearing knee and they just mention one of those two, that's what they're talking about, is that the knee's got angulation on it. So sometimes the joint space on one side is going to be less open than the joint space on the opposite side. So just be aware of that. Don't be taking a whole lot of repeats on patients with just bad knees. But then you want to see the trabecular markings as well. So the AP of the knee should look like that, and this is pretty healthy AP of the knee. This slight little bit of a density or decrease in density right there, you see it? That is the kneecap. Okay, so the apex of the kneecap, if you remember, is at the bottom of the knee. The apex of the knee is all the way at the bottom. And so our central ray is going to be just inferior to the apex of the knee, and it should be right at the top of the joint space. Get a little bit of superimposition there, and that's what AP should look like. So on the lateral, everything in the ankle, foot, and all that, we made the distinction that it's best to put the medial side down because it's broader and the magnification issues we talked about before. Well, the knee, there's no way to put the patient into that position. So you're always going to rotate the patient to the affected side. The only time that you might shoot a lateral medial on a knee is if it's cross table, and that's perfectly fine if you do. But if you're putting the patient, you have the patient on the table, what you're going to have to do is you're going to have to rotate them towards the affected side. So the affected knee is going to be flexed and bent forward. The unaffected extremity can be either behind or in front of. And in all honesty, in my experience, I had a better luck getting the unrotated knee going the opposite direction, having the unaffected knee in front of the affected knee. What you can't do is just tell the patient to kind of roll over into a semi-prone position, because it's going to rotate the pelvis and it's going to rotate the knee towards it as well. So what you're going to have to do is get them into that position and rotate them back to where the knee is perpendicular. So if the femoral condyles are parallel on the AP, then what do they have to be on the lateral? Perpendicular. Right, so that's going to be your anatomy to put perpendicular to the image receptor on your lateral is a femoral condyle. So when the text says to bend the patient's knee and extend it forward, it's not talking about bending it real sharply. It's only a 20 to 30 degree bend, and anything beyond that, you bend it more than that, it closes the joint space. You straighten it any more than that, and it closes the joint space. So what we're trying to do is make sure that we've got a good opening of the joint space between the distal portion of the femur and the proximal portion of the tib fib. Femoral condyle is perpendicular to the image receptor. They should be superimposed, and the patella should be perpendicular to the image receptor. So we're going to talk about the sunrise here in a bit. A lateral knee is something that we're going to look at for a sunrise. Fundamentally, the biggest difference between a lateral knee for a knee and a lateral knee for the patella is the degree of bend in the knee is going to be less significant, like 10 degrees from patella. So what we're looking for here is not the joint space between the patella and the femur. This is between the femur and tib fib. All right? So that bend actually closes the joint space between the femur and the patella. It rotates the patella down over the anterior portion, not directly over, but closes the joint space. It makes it closer to the femoral condyles. So we don't want to do that. So if we're looking for the patella, two things. One is if the patient is suspected of having a patellar fracture, we're not going to shoot the sunrise first. We're going to take a look at a PA projection. We'll talk about it in a minute. And we're going to look at the lateral to determine whether or not the patient possibly has a broken patella. Because, just like on the Achilles, the patella, the kneecap has a tendon that attaches to the top and the bottom of it. So when you bend your knee, it's going to tighten that up somewhat. And if you've got any kind of fracture, what it could do is further separate the fracture, and you don't want to do that. So anytime we're looking at the patella, we're going to look at the lateral and the rather than the AP. We might shoot AP if we're just shooting the knee, but if we're ordering just patella itself, we're going to shoot PA. Why would we shoot a PA? Puts it closer to the IR, and what does that do?
Less magnification.
Less magnification and better sharpness of reported detail, right? So PA projection to improve sharpness of reported detail. That being said, we go back up to the AP of the knee. Can you see the patella very well? No, it's really tough to see it. So it becomes very important to increase your collimation to try to, improve the visibility of the patella itself. It's not easy to see over that big fat femur. All right, now on the lateral, on the AP, remember we're going to have different angulations, right? If you're hypersthenic, it's going to be a cephalic angulation. Asthenic, it's going to be caudal angulation. But on the lateral, everybody gets an angulation. And that is because looking at the femur, can you see how the medial condyle is distal to the lateral condyle? Can you see that? Okay. So if you shoot perpendicular, what you're going to see, if you don't put any kind of angulation on it, what you're going to see is the medial condyle projected lower than the lateral condyle. So what we're trying to do is put an angulation on the central ray, and most people are just going to use 5 degrees, and put a 5 degree cephalic angulation to project the medial condyle on top of the lateral condyle. Does that make sense? So where we have different angulations for different body habitus on the AP for lateral, everybody gets an angle. Everybody gets an angle. Once in a while, you'll see somebody, they'll have a perpendicular central ray for lateral knee, and they'll say, well, it's because the patient is sthenic body habits. Should that matter? Answer is no. Everybody gets a 5-degree angulation for lateral of the knee. All right, so again, your central ray is going to be to the level of 1 inch inferior to the patella, right through the open joint space. So we're going to look for evidence of proper collimation. We're going to look for the volumization of the joint space, providing the patient doesn't have severely arthritic knees. But what we're also going to be looking for is the condyles. All right, so if I position this just perfectly, look at that. We can see through the hole that goes all the way through this thing so that we can hang it on a frame, right? So if we're seeing through that hole, then we're perfectly superimposed, right? But if we're not, can you kind of see how this, in this case, it would be the medial condyle is projected below the lateral condyle, and if I rotate it a little bit, you can really see it, okay? So that's what you're going to be looking for. Anterior to posterior rotation is going to separate them anterior to posterior. But if your angulation is wrong, what you're going to see is 2 little bumps, okay? And those are your condyles. So if you see 2 little bumps, one anterior and one posterior to the other, you've got rotation. So which way is the patient rotated? It's tough to say. It really is. They look so similar, it's tough to say. But if you got superior to inferior separation, you're going to see a bump and then another bump below that. And that's usually because of a misangulation or a failure to angle. You had a sthenic patient and you forgot to put an angulation on it. Okay? So you're going to look for those things for rotation. So good lateral knee should look like that. And even here, this is about as good of a lateral knee as you're going to get. But even here, can you see how you've got a little bit of a separation between the 2 condyles on the posterior side? Okay. That's what it'll look like. But that's not enough to really get upset about. You can see just a shadow here, shadow here, shadow here, shadow there. That's fine. What you don't want is gross separation between the 2. But that's okay. It's really, really hard to get a perfectly positioned lateral knee with no presence of rotation whatsoever. So a weight-bearing knee, just like weight-bearing feet, where we're evaluating longitudinal arch, weight-bearing knee, the patient provides the weight. You don't have to have the patient hold on to anything. The patient's weight provides the weight. And most of the time we're doing weight-bearing knees, we'll do them bilaterally so that they can compare the 2. And it's usually pre-surgery. Sometimes your equipment will have a measuring device, an external measuring device, like you may have a yardstick that is just a big piece of wood with some metal numbers on it that you may have a patient stand next to. And that provides a reference for how tall the patient should be, how long the prosthetic should be. And if they mismeasure and they put the wrong length of prosthetic, be it a hip or a knee, into the patient, then that can affect, or if they mismeasure and they cut off too much bone, that can affect the patient's walk, right? So previous department chair before me, her name was Nancy Wardlow, and she had a hip replacement, and they mismeasured just a little bit, and she was having problems with her hip. It was just all the time aching, even after she had her hip replacement. And sure enough, the prosthetic was just a little bit too short, so she had to walk around with a insert in her shoe just to make her walk straight. Pretty insignificant. That fixed her right up. But I did have a patient one time had his hip replaced, and it was so bad that the only time I ever saw him was in the ER. and it was because his hip had dislocated. And he was just driving down the road, and he reached over, hit the brake, and his hip dislocated, just popped out of joint. And he said it happens so often that when it does happen, all he has to do is lay down on the ground and roll around a little bit, pop right back in place. But he couldn't get out of the car, so EMS showed up, pulled him out of the car, put him on a backboard, wouldn't let him roll around, and he actually reduced his own fracture on the ER table. We were just sitting there, and all of a sudden we heard, he said, "That's it, it's in." He could move it just perfectly. And he was good to go, he was ready to go, but EMS wouldn't let him do that, so it cost him a hospital visit and the time and all that. So it can be significant. So know your protocols. If you're doing weight-bearing knees, make sure that you include whatever equipment the doctor might need in order to make those measurements, because it can make a big difference on the patient's outcome post-surgery. Oh, the other thing about weight-bearing knees is that, remember, all of the angulations that we're shooting are an attempt to put the central ray parallel to the tibial plateau. And when you're standing up, the tibial plateau is pretty much parallel to the floor, all right? So your central ray just needs to be horizontal. You don't need any kind of angulation on central ray for weight-bearing knees. So it's perpendicular to the image receptor. Some of your docs, and I think there's a picture in the textbook where the patient's standing up, but they've got a slight bend in the knees. Again, know your protocol. I've never worked in a hospital where the protocol was to have a patient stand with a bend in their knees. But I guess it's a thing. So central ray is horizontal, perpendicular to the image receptor, entering the same place, ½ inch below the apex of the patella. And it should look like that. Sometimes your hospital protocols are to shoot an image from the hip all the way down to the knee. All right, so oblique of the knees. Sometimes your hospital protocols call for 2 obliques. Most of the hospitals I've worked in that did obliques of the knees only did 1 oblique. So you got internal, external rotation, both at 45 degrees. So for lateral rotation, essentially what you're going to do is you're going to have the patient on the table and have them relax their foot, and their foot's going to come out to pretty close to a 45-degree angle. All right, so you might adjust, and when you're telling the patient to rotate, and we're looking at the knees, make sure you don't just tell them to point the toes, because there's a certain degree of adduction and abduction that you can get off of your foot by itself. So grab them by the distal portion of the femur and tell them to rotate, right? So rotate until the femoral condyle is 45 degrees, and this is what you get. Increase in superimposition on the proximal end between the tibia and the fibular head. Now see that? So AP is here. External rotation does that. Okay, so 45-degree external rotation, you're going to see a portion of the shadow of the patella out to the side, but you just don't see a whole lot there, right? The internal rotation, though, is 45 degrees, and you see separation between the proximal portion of the tibia and the fibula. So every hospital I've ever worked in that shot obliques of the knees, if there was a 3-view knee, AP, a lateral, and an oblique, it was always external oblique so that you could see that. Okay. Never worked in a hospital that did 4 views. They exist, but if you work in a hospital that does 3 views, I can almost guarantee it's going to be AP, lateral, internal oblique, so that you can see the separation.
Wait, internal or external?
This is internal.
Oh, okay.
Yeah. Internal oblique shows the separation. External oblique is going to show, or lateral rotation oblique is going to show increased superimposition, decreased superimposition with internal. And that's, oh yeah, and by the way, we're back to the angulation for the obliques. So same angulation as before, 19-24 degrees, or centimeters. We have a perpendicular central ray, and below 19, we've got a caudal angulation. So asthenic caudal, and a hypersthenic patient will get a cephalic central ray angulation. Otherwise, both of those are identical. So, which one is that? Well, you see the separation between the proximal end. You see a little bit of patella on the external oblique. You'll see a little bit of patella over here, but that's what you're seeing this, or what you're doing this for, is that separation right there. Yeah, external oblique looks like that. Okay. We've got two views of the intercondylar fossa by itself. Both of them are a PA axial. It's just a matter of how we get to that PA axial. One is a Hamblad and one is Camp Coventry. And full disclosure, never shot either one of these in my entire career. It's on every registry test. It's in every registry review book. So it's probably going to be on your registry. I don't know that you'll ever shoot it. All right? But it's there, so we got to cover it. All right, so the Hamblad method. Make sure that the patient can perform what it is that you're asking them to do. The older a patient gets, the more fragile and more painful their knees get. So assess your patient and their ability to perform what we're going to ask them to do. But with the Hamblad method, what we're going to have is the patient either standing with their affected knee on a stool, probably not going to do that, standing beside the table with the affected knee on the image receptor, probably not going to do that either, or having the patient on their hands and knees on the table. All right, the other two, you're going to have a problem with the patient's stability, especially in older patients. So I really don't recommend options 1 or 2. Just get the patient up on the table if you're going to do the Hamblad method. All right. So what you're going to do is you're going to have the patient on all fours, and you're going to lean them forward until the knee, the femur, is at a 70-degree angulation with the tabletop. So if the patient is truly on their hands and knees with their femur perpendicular to the table, that's 90 degrees, right? So you're going to have the patient lean forward about 20 degrees so that their femur forms about a 20-degree angulation. So instead of having the femur here, it's going to be about like that. So lean the patient forward a little bit. And what we're trying to do in doing that is we're trying to, there we go, we're trying to put the central ray more parallel and shoot right through the intercondylar fossa, through that area right there, okay? Now, if we put it perpendicular, then you've got the head of the femur and the rest of the femur possibly projected right down onto the top of it. But if we angle the patient forward, then you can see it a little bit. We go 20 degrees, not just to get that out of the way, but you've got a lot of soft tissue right there too, right? We want to get that out of the way as well, so we're going to lean the patient forward so that we can see right down through the intercondylar fossa. Okay? So that's a Hamblad method. Central ray goes right through the intercondylar fossa, right between the condyles, and we should see open intercondylar fossa without rotation, and looks like we've got a little bit of rotation on that, but that's what it's going to look like. It's going to look basically like an AP of the knee with a big hole. Okay? So if the patient can't do this, if they can't get up on their hands and knees, their knees are real painful, and they can't get up onto their hands and knees, then what we can do is we can angle the central ray. And remember, anytime we've got an angulation on the central ray, we're going to have distortion. But we can do that. So if we lay the patient on their stomach and we bend their tib fib to come up out of the way, to get it out of the way, we can angle the central ray down through the intercondylar fossa and kind of, sort of, get the same thing, okay? And that's what we call the Camp Coventry. But you should be able to see the difference between the Camp Coventry and the Hamblad if we look at both images. So the Camp Coventry, what we're going to do is we're going to put the patient onto the table, and if you see in the textbook, they've got the tib fib elevated. right? So the patient's laying on their stomach, you're gonna flex the knee 40 to 50 degrees just to get the tib fib out of the way so that you don't project the intercondylar fossa directly down onto the tibial plateau. So you're gonna have to put the foot on something to keep it at that 40 to 50 degree angulation. Then your central ray is gonna be 40 to 50 degrees caught at, right through the intercondylar fossa. Alright, and what you're gonna get is that. Can you kind of see, if we look at that one and then we pop back to the other one, you see how stretched out this looks compared to that? So we've got some distortion, but is it acceptable distortion? Yeah, if the patient can't do this, then that's maybe the best we can do. Okay, so Camp Coventry, what you're gonna be looking for on the test question with Camp Coventry is the patient's tib fib is elevated, that's hint number one. Caudal angulation, that's hint number two. Angulation on the tib fib, that's hint number three, we're talking about the Camp Coventry. 40 degrees, 50 degrees on either one of those, Camp Coventry. The only angulation you're gonna be looking for the Handblad is that 20-degree angulation where the patient's leaning forward. So it's either gonna be the patient leans forward 20 degrees or the femur forms a 70-degree angulation with either the tib fib or the plane of the image receptor. So 20-70, Handblad. 40-50, Camp Coventry. Elevated foot, Camp Coventry, right? So on the patella, we talked about this some. For the patella, we're going to shoot the patella PA for the reasons we talked about before, with decreased magnification and increased sharpness of recorded detail in a structure we're going to have a hard time seeing anyway. So to get the patella truly parallel to the image receptor, you might have to laterally rotate the heel a little bit. So so lateral rotation of the heel would be to bring the heel out that way just a little bit to get the patella to superimpose directly over the distal portion of the femur. Okay? So 5 to 10 degree lateral rotation is not very much. Don't overdo it. Central ray is going to be to the mid-popliteal area, so it's really to the back of the condyles, almost as if you were shooting for the intercondylar fossa. So all the same stuff we're going to look for on everything else. Proper collimation. In this case, we want the patella completely superimposed on the femur, no rotation, and it should look like that. So again, very difficult to see, but you can see in this case, it's going right through the joint space. This is the apex of the patella all the way down here. Can you see that squiggly line right there? And then where they're pointing up here. So some of your patellar fractures, flat bone fractures, will be what they call stellate fractures. Stellate sounds like star, right? So, or stellar. So what they do in a lot of cases is they'll fracture in multiple planes, kind of like a star. So they kind of shatter. So lateral patella, again, our flexion of the knee for lateral patella is only going to be 5 to 10 degrees instead of 20 to 30 degrees for the lateral of the knee. That's so that we get a good joint space between the patella and the femur. Again, we're not looking for tib fib patella, we're looking for femur. We're not looking for femur and tib fib, we're looking for femur and patella. So 5 to 10 degree flexion of the knee, so it's almost fully extended. And then the other difference would be your central ray location collimation. We're just looking for the patella, so you're going to focus on the patella and you're going to collimate down to the patella itself. You don't need to include the entire knee for a lateral patella. So perpendicular central ray perpendicular to the image receptor and it enters at the mid-patellofemoral joint space. And you could even collimate down below that. So between the PA and the lateral of the patella, we should be able to see some fracture lines. Neither one are going to be ideal, but we should be able to see some fracture lines. These you can actually shoot tabletop, or you can remove the grid and shoot into the table bucky. You don't need a grid since you're just shooting through a very small bone. For the PA, you're probably going to need a grid, but for the lateral, you could do it tabletop or without a grid. So we want to look at the PA. We definitely want to look at the lateral before we have the patient put much of a bend in the knee at all. But once in a while, you get an order for what we call a sunrise view. The sunrise and the setagast are the same view, all right? So on the test, if there's interchangeable words there, then that's fine. Understand they are the same thing. So you're going to look at the PA, you're going to look at the lateral to make sure that you don't have any kind of fractures, but especially a transverse fracture is what you're going to be looking for there. All right, so how you're going to do this is you can do it prone with the patient laying on their stomach, and if you're shooting it prone, you bend the knee up behind the patient and support the knee. Have the patient do the bend, and just ask them to bend as far up as they can. They don't need to bend beyond 90 degrees. So it gets a little bit confusing, because we have a tendency to look at 90 degrees as this, right? But when the patient's on the table, and if you're doing this prone, that's easy. If you're doing it prone, then that's 90 degrees, right? But if you're supine, which is the other way to do this, it's a little bit more confusing because you don't have that definite T effect. But this is 90 degrees, right? So if the patient's laying on their back and they elevate the foot, is that not the same? Okay. So, I've seen students kind of confuse the 90-degree thing, and they think that they absolutely have to get the tibia at a 90-degree angle. So I walk into the room, they're like that. Don't do that. Right? That's well beyond 90 degrees. That's probably, I don't know, if that's 90, that would probably be about 110, 120 degrees. Okay? So keep that in mind. The 90 degrees is 90 degrees on the knee joint itself. But prone, it's easy to see. You get the tib fib vertical. So looks like that. And your central ray, angle to the femoral tibial joint space, and it should look like so. So 15, 20 degree angulation. What I generally do is have the patient lay down on the table, and I put this all in caps because look at what we've got going here. All right. First off, the x-ray tube in a lot of cases is not going to go down low enough because of the presence of the table. The x-ray tube and the handles are going to bump onto the table before you can get the x-ray tube that low. So what you may have to do if you're shooting a sunrise view and you're shooting it like this instead of with the patient prone, is what you may have to do is scoot the patient down towards the end of the table so that you can lower this down lower than the table. Does that make sense? Because you can see that this is lower than the table, right? So you set the patient up onto the table, you bend the knee up until the knee's at a 90-degree angle. That's probably a little bit beyond 90 degrees there. And you have the patient hold the image receptor there. What's right on the other side of the image receptor? The face. Where do you wear your TLD?
Right there in the collar.
Right there in the collar. Why? Because you want to measure your thyroid dose? Well, they're shooting directly at. Okay, if you're going to do this, lay the patient down. Don't sit them up so that you're shooting directly into the face. You can also cover them up, put a shield on them, but definitely don't sit them up and do that. Okay? So it can be done tabletop because, again, we're shooting through a very small anatomy. Scoot the patient down to the end of the table. Put the image receptor directly on top of the patient's distal portion of their femur, central ray perpendicular to the image receptor. Much easier than, I think, than flipping the patient over onto their stomach. And either way, you get the same thing. Yeah?
What about in a chair? I was at Fifth Street and I saw him doing it in a chair, like.
Yeah, I've never done it in a chair, but yeah, you absolutely could. Did they angle the central ray from above or from below?
I think from above.
From above?
I
It
think
might
they
have been
were
a
all
merchant
the way-
view. Did they do both of them at the same time?
I don't
You
remember.
don't remember?
But I just remember the person was all the way on the edge of the, like, seat. And
Yeah.
they're like,
Yeah. There's another view that's very similar to this. It's called a merchant view.
maybe that was it.
Yeah, and the merchant view does bilateral patella.
Okay.
And it doesn't give you exactly the same look, but it's very similar. And some of your, especially doctors' clinics, prefer the merchant view over the patella, or over the sunrise for, and I'm not real sure why. They've got a reason, I just don't know what that is.
Yeah. I have noticed that clinics are different from the hospital.
Yeah,
It's kind of confusing.
yeah. And it's all because you're shooting for the doctor in front of you most of the time. So this is why they call it sunrise, is because it looks like the sun coming up over a valley between a couple of mountains, right? Kind of a cool view, right? So, again, that's just all same stuff. Okay, so the femur, everything that we've talked about so far, you know, you might use grid for, you might use grid for knee. You know, some hospitals, I've seen them actually not use grids routinely for knee. The general rules of thumb for grid use are 10 centimeters or above, which equates to about the size of your shoulders, size of your knees. So some hospitals may or may not use a grid for the knee. Once you get to the femur, you're gonna need a grid because the soft tissue is just too great, okay? Where we had some flexibility in positioning for a tib fib, we don't have that flexibility with a femur. On tib fib, remember I talked about the anatomy maybe being too long for the image receptor, so you had to put it on kind of catty corner, going from corner to corner. On the femur, you can't do that because you have to be in a bucky. Since you're gonna be in a bucky, the only way that you can get them on their catty corner is to hang them off the table, and you're just not going to do that. So on the femur, what you're going to have to do to include the entire femur is to include an AP of the proximal, AP of the distal, lateral of the proximal, lateral of the distal. Some of your hospitals will allow you to shoot like an AP to include one joint and a lateral to include the other joint, okay? So again, know your hospital protocols. Some may want both APs, you know, AP proximal, AP distal, and lateral proximal, lateral distal. So know your protocols. The other thing is, because we've got such a big, long anatomy, and divergence of the central ray plays a part here, we're gonna need an image receptor beyond the joint space. Right, so we need to make sure that the image receptor extends 2 inches beyond the joint space on both ends. So it's not just the length of the anatomy, but it's the length of the anatomy plus 2 inches on both ends. Rotation of the femur is going to be dependent on what it is you're trying to see. Right, so if we're looking at AP, then our AP of the distal end is going to be just like the AP of the knee. And that is, we're going to put the femoral condyles parallel to the image receptor. And this doesn't really show it all that well. It's a little bit subtle and difficult to see, but if you look at the shadow, you can see it a little bit better, okay? So most of our femoral fractures are actually going to be fractures of we call them hip fractures, but it's proximal end. So it's going to be, described this last week, intertrochanteric hip fractures or fractures of the femoral neck. So that puts the femoral neck parallel to the image receptor, but look at the femoral condyles. Are they parallel? No, they're not. So if you're shooting the distal end, the AP for the distal end, what we need to do is we need to focus on positioning like a knee so that we take the femoral condyles and put them parallel to the image receptor. But if we're looking at the proximal end, what we're gonna have to do is internally rotate the toes about 15 to 20 degrees. And again, two things. One is evaluate your patient. Get a history on the patient. What did you do? What happened? Take a look at your patient. If you sit down on the floor or lay down in your bed or whatever, how is your foot oriented? You sit down, just flat on the floor, extend your legs. Is your foot all the way out to the side most of the time? No. You lay down in the bed, is it all the way out to the side? No, it's not, most likely, unless you're really, really flexible. It's probably not. It's probably going to be at an angle about like that. So look at your patient, evaluate two things. One is if their foot is all the way out to the side like that, pretty good chance they got a broken hip. Are you going to tell them to internally rotate the toes? The answer is no, you're not. So take a look at that. Also, the other thing is kind of counterintuitive. If the patient has a broken hip, they're going to have a tendency to be rotated a little bit towards that hip. To get comfortable, they'll ask somebody to put something under the opposite hip. All right? So if they're a little bit rotated towards the hip of interest, good indication they got a broken hip. If their foot is out to the side, definitely take an x-ray before you have the patient rotate the toes and see if the patient possibly has a broken hip. So don't rotate it if the patient has a broken hip. But if they don't have a broken hip, for the AP, if you're looking for the proximal end, you're going to internally rotate the toes from the femur, from the hip. Don't just tell them to point their toes, because that's what they'll do, is they'll just point their toes and the hip won't rotate at all. Internally rotate 15 to 20 degrees if they don't have a broken hip. You're going to forget that at some point, probably very early on, and you're only going to forget it once. But what you're going to get is, instead of that on a hip, you're going to get that, because the patient's going to have a relaxed foot and it's going to be pointing out 45 degrees, and somebody's going to look at your film and they're going to tell you, go take another one, and this time internally rotate the toes. Okay, is there any world where that and that look anything alike? No. So if you get that and somebody says, this time go internally rotate the toes, what's your answer? Okay, yeah, take a look at it and you can see that you don't see a neck, right? So you know what you did wrong. Don't argue with them, just say, okay. So internally rotate, I said 15, 20, it's 10, 15 degrees. So what you should see on the proximal end is this. They've got some sort of little calcium buildup there. Don't really know what they've got going on. Doesn't really matter. And the distal end, we've got basically the AP of the knee. This is not the same patient. This patient has what looks like, aside from that, relatively healthy bone, and this patient here, see how dark the bone looks? See how almost non-existent the joint space looks here? All right, so this is definitely an older patient. Looks like they've got a fracture here. It's tough to see, but can you kind of see a little bit of a line right there? It's a very subtle looking look to it, but I think they've got a fracture. So this patient looks like they've got osteoporosis, actually. The cortex of the bone is very thin, and it just doesn't look very robust at all, probably osteoporotic patient. All right, so lateral of the femur. Here's the thing. For lateral of the femur, the distal end is positioned just like a knee. All right, so it's easy to get to. But you can't get the whole thing on one image for two different reasons. One is the image receptor is not long enough, and the other is because the pelvis is here, right? So you got the ball and socket joint, and then you've got the anterior pelvic bones that extend below that. So you've got too much bone to shoot directly through. So what you're going to have to do is angle your central ray up through in between the patient's legs, perpendicular to the femoral neck, in order to get the proximal end. You just can't get this on one view, a lateral of the femur. So if you work in a hospital that allows you to take one view to include one joint and the other view to include the other, what I recommend that you do is take the AP to include the hip joint, and the lateral to include the knee. Much, much easier than getting a lateral of the hip, okay? But some of your hospitals are gonna require both, so, there's that. So what you're gonna do for lateral is flex the affected knee about 45 degrees, and that just gives the patient some stability to lay on. Place femoral condyles perpendicular to the tabletop, just like what you did for a lateral of the knee. If you're shooting for a lateral of the knee, you're gonna put the bottom of the image receptor about 2 inches below the knee to make sure that you get the entire thing. So you're gonna get the distal condyles and as much of the femur as possible for the distal end. Proximal end, we're gonna have to do some other things. Okay? So what you should see for the distal end is that right there. Notice that we've got separation of the femoral condyles. See the way that they're separated, you got a kind of a bulb here and another one there. They're separated vertically, right? Which indicates that the lateral condyle is projected inferior to the medial condyle. So we didn't want that on the knee, but on the femur, we're shooting perpendicular. So we've got two different things. We've got the natural lay of the femur where the medial condyle is distal, but we've also got divergent central ray, which effectively puts a central ray angulation on the distal end. You're gonna have that separation, okay? So you don't wanna see that on a knee, but on a femur, that's okay, right? So the proximal lateral femur, if the patient can tolerate it, and if they can do it, then the easiest way to position for a lateral femur is to externally rotate, all right? So what you're gonna do is you're gonna oblique the patient up, or AP, you're gonna oblique them up, they put a wedge sponge behind them so that we'll get the patient's femoral condyles perpendicular to the image receptor and just externally rotate the femur until the condyles are perpendicular. So we have no femoral neck, but if your patient's got a broken hip, they're not gonna be able to perform either the AP or the lateral like that. What I recommend for positioning for the AP views and the AP with external rotation is that you find the patient's ASIS and put the top of the image receptor at the ASIS, very top of the image receptor at the ASIS, and then take your line of collimation, longitudinal line of collimation, which just had a hole in it, but ASIS is right there, right? So this should fit more inside of this socket joint, but you got your ASIS right there. If you come straight down from the ASIS, what you're gonna find is the femur, the length of the femur, okay? So if you put the top of the image receptor at the ASIS right here, then this longitudinal line of collimation should be parallel to your femur and directly on top of the femur. Does that make sense? Okay, so that's your centering point. When we get into hips here in a minute, they've got a very complicated description of how to find that. The easiest thing to do is just put the top of the image receptor at the ASIS, a longitudinal line of collimation coming straight down the femur, and you're gonna hit it every time. You're gonna eventually run into a hypersthenic patient, and some of these people have legs like this. And you're gonna take a look at that patient, and you're gonna say, wow, where do I center for this? You gain weight, everybody in here's gained weight and lost weight at some point in your life. Does your bony structure change at all? No. So regardless of how big the patient is, top of the image receptor at the ASIS, that longitudinal line of collimation going straight down the parallel with the anatomy, and you're gonna get a good femur, good AP of the hip, okay? Don't let the soft tissue throw you. So common leg, knee, and Femur fractures, very common mid-shaft tibial fractures. Make sure that if, you know, you've got a patient on a backboard, they came in a car wreck, just assume the patient's got a compound fracture of tib fib. You know, if you get an order for a tib fib, just before you see the patient, assume that they've got a compound fracture. So what is compound fracture? Open fracture, what is it?
Sticking through the skin.
Yeah, bone sticking through the skin, right. So do you think the patient might have bled? Yeah, so glove up, right? Before you even get in there, glove up. Anytime you're working a trauma, look at the backboard. The worst needle stick I ever took, and I've had two, wasn't a needle stick. It was from broken glass. So we were working trauma, and this guy was an IV drug user. And he had broken glass all over the backboard. And I think there were 7 of us got exposed to this guy that night. But, you know, they didn't clean the glass off very well, and people were just grabbing the backboard, even with gloves on. There's exchange blood going on there, right? So look at what you're doing. Make sure that you got your gloves on, because what may happen is you might walk in and you can see the leg and you can't see any blood, and you reach up under the patient and somebody has wiped the backboard up. Now, if you don't have gloves on and you've got both of your hands up under the patient and there's blood all up under the patient, you're exposed. Right, so put your gloves on anytime you have a femur fracture. So proximal tibial fracture, you'll have what they'll call a tibial plateau fracture. It involves plates and screws. Distal femur fracture also would involve plates and screws. A patellar fracture, don't see a whole lot of them, but you do see them. Mid-shaft femur fractures can be very dangerous because of the big arteries that they've got running, you know, just right there in the parallel to the femur. So, a lot of different ways to fix them. This is what we call an external fixator here. External fixator, the framework that provides the stability in the fracture is sticking out of the patient's skin. So we've got these rods that go through the patient's bones, and then this thing kind of acts as an exoskeleton, kind of like a bug, until the bone heals up. Plates and screws, I've never seen a plate that long. That's crazy right there. But plates and screws in the distal portion of the tibia are very common. Tibial plateau fractures, so we got screws, plates, patellar fractures, and that's just gotta hurt. Distal femur fractures, you'll have what we call intermedullary rods, and that's what this is. They'll punch a hole in the patient's hip and just. If you've not been to surgery before, anybody not been to surgery, seen an orthopedic case, they can be a bloodletting, and this is probably the worst of them, IM rod. And it doesn't, you know, before I came to TJC, before I left Tyler and came back, that was my job, was I was working kind of a late day shift in surgery at ETMC. And so the students come down as a group, and I give them orientation around the OR. And, you know, you always have one or two that was just this idealistic, oh, wow, this is just so cool. It's just like in the movies. And then we'll walk past an orthopedic room where they're just hammering a rod into somebody's femur. And in an instant, they switch from, this is so cool, to this is barbaric, this is disgusting. How do you treat people like, you know? But yeah, to get that rod in there, they've got a big, long drill bit that they run all the way down and hollow out the medullary cavity, and then they put a slap hammer on it. A slap hammer is just a big chunk of metal on a rod, and they just wail on it until it goes all the way down into the knee and put screws across it. It is awful.
They're gonna say awesome.
It is in its own way, but it's, you know, it's like, oh man, I'm glad this guy's asleep. All right, so why don't we take a break, and then we'll come back and we'll run through femur, pelvis stretch.
just have it in these for, but that's easy, I can do that, but I just don't like doing it. Oh, I didn't do the word search, because I wanted to set up for me and Kirby, because I think Kirby likes this. So, I think it was over here. Okay, yeah, okay, so it's number 20, of the lower extremity, and it says, during digital imaging, what is the term that describes the post-processing of 3 images into a single image of the entire extremity? And I found this just now, which makes the 3 images up there, but I guess that would be called the upright leg measurement procedure, or, cause I don't know.
I haven't even looked at the book yet. Either of them.
You did this, right?
No. Just letting you talk to me. No, I haven't done that.
Well,
I'm gonna try to do it before Snoop today.
Cody was like, well, I suggest that, she was, I think it's, that y'all should have that book done already by Sunday, and I was like, okay.
Who said that?
Told me the date Friday, and I was like, okay, so Saturday and Sunday, what was I doing? Working on this book, and I got it almost all the way finished.
How many pages is it?
Lower extremity is a lot. The pelvic though is not a lot. So, but I think I know this answer now. I didn't know it, but now I know it. I think.
Very neat.
I'm gonna call it the.
My defense, I didn't know this weekend was gonna be so slow. I would run it.
Yeah, I need to bring it tomorrow to clinicals, or not this, but I need to bring my something to study. I really need to study trans class. But yesterday I was doing physics. I was listening to the last physics lecture on Friday. I was listening to that all the way over here, and I finished it. But if I need to watch it again, like, and write more notes about that one, because I wrote the notes in the first one. I got all that done because I'm trying to make an A on this test. So, yeah. Anyways, it's a little mess.
Then I'll try to do physics again tonight. And, write notes too, so that if you wanted to study during clinicals, we can.
Okay. Sounds good to me, because I need to know my physics. I know we're for sure doing math during this one. But,
And so I was like, well, maybe my email company hasn't emailed me back. But I was like, can we know what else not to focus on?
Yeah,
But he hasn't
because so
even-
far, the only thing he cut out was the map
circuits?
for the circuits.
Yeah. And so, yeah.
I was like, there's no way.
Yeah, that's what he said. He's like,
What?
there's no way.
For the, combine the two part 1 and 2 chapter
For
4.
physics. So I was wondering if he had said anything else that was gonna be not on this deal.
so y'all watched the first and second video, right, of physics?
I haven't watched Friday. I was here.
Okay, well,
Wednesday.
on the first video, did y'all see how he was like talking about the magnet of the North and South Pole?
Mhm.
And he said,
Yeah.
he even drew on the board that it went from the south to the north, but in the book and in the second one,
North to the south.
so I'm confused.
I was confused about that too.
I had to ask him about that because I feel like he meant to say the north to the south.
Yeah, because I saw that. I was like, wait. I wrote that down. It says south to the north.
I
It
think,
has the north to the south.
yeah, I wrote that down too last night, and I'm like, that does not look right.
I just asked.
Yeah, I'm gonna ask him
Okay.
when he comes back in because he's gonna get somebody really mad about that on the test. Mostly me, if I was the one to pick that answer. Guess
So we
there's
have
some
physics
magnets.
Friday and, patient care,
Hmm?
No, I think
It's
it's
just
just
physics.
physics.
And then all the tests and things.
Yeah.
Okay.
I was like, wait.
So, hold on. Let me get my
So
calendar.
just study physics, what you're saying.
so physics is only this Friday, so what is,
Everything else is next week.
We got physics this Friday?
Yeah.
physics this Friday and everything else next week?
I had no
So,
idea.
do y'all, okay, I know for sure that intro is on Monday,
The 26th, yeah.
but what's
is
the other ones on?
Chill.
Oh, positioning's on Monday too.
Positioning. Mhm.
Hold up. Hold up. I'm all
And then-
lost.
What about patient care? Do we know?
Do you have lab Wednesday or Friday?
Friday.
Then it's Friday.
And so is your practical Friday too.
So
Next
patient
Friday?
care and practicum next Friday.
Mm-hmm.
What is it?
Patient care
Oh
and a practicum.
And then intro and positioning Monday, or next week.
Yeah, so we have physics this Friday. Right,
Oh, and for patient care, we had that bloodborne pathogen workbook also.
what about that? Is that due?
She told us to look at it, I guess read it, and I guess it's like a workbook type thing.
That little tiny.
The bloodborne pathogen one.
Did it have questions to it?
I don't know, I haven't even looked through it, but she told us.
I looked in it and it was like, I don't know, there was like no point of it. Like, I was looking at it and
I know
closed
she
it
said
up.
we're getting tested over it. She's like, don't spend too much time on it. She's like, we're just, something about, they have to make sure we can read or something like that, and that's what she's gonna use. I don't know.
All day.
Okay.
It literally, she was about to forget to tell us, and I took a picture of the thing, and I was like, wait, it says bloodborne pathogen. She's like, oh yeah, I forgot to tell you.
Yeah, that wasn't in a video.
Yeah, it wasn't in the video, like literally she
For
told
the
us
Friday
like,
people.
she was walking out the door, she's like, oh yeah, I forgot to tell y'all, that bloodborne pathogen book, y'all, it would be very smart for y'all to look at it
Before which test?
before the test next week.
Intro?
Patient care.
And then that.
Wait,
The whole book, they want me to read the whole book?
Patient care and-
Yeah, I don't know how detailed it is.
I don't
Yeah.
know.
Oh my God, I'm so
Okay, I have to go home today and do things. Actually do. Not always, but you know what I mean. We're busy, I get that, you know, there's just no way.
I can see.
You need to, you don't all by yourself, but you need to at least attempt it.
Oh, I'm
Oh,
gonna
yeah,
start
she's
with a
got a long
workbook
time
for this
to work
class.
to do.
A workbook for this class.
You're almost
We can have a whole thing alone and
Or
then.
it's chapter 7 and 8. 7 and 8.
I'm just telling that.
Yeah.
No, I want to do
I think I have this
I
one.
like getting
I'll
all
have
the
to
check off.
check it.
I just wanted you there.
If I come.
Well, it just says for all.
I don't know.
Oh, yeah.
Some of it's the same stuff over
Oh,
and
good.
over.
I just really study the self-test thing.
Yeah.
Like when I'm already done looking over this, I go
I gotta
for
go
the
get mine.
self-test and.
Gotta go to my mom's though. I'll just bring
I'm going for these. I'm working on my whole test. I'm over on Saturday.
I'm
This
worried
workbook.
about that.
But
Getting that
I will try to do it today. Cause I was like,
We don't have to label it. I remember labeling it in A&P.
That's literally what I was thinking. Oh, look, I got so excited. Cause I've.
You gotta know something in that.
I know, you showed me.
Oh, yeah, for practicum. Oh, like this.
And like, they just added it here, but I feel like I'm gonna get too much, which I'm gonna be sad about, but I'm gonna put them right here. I don't want to put them right there. But I'm so.
It's kind of like the.
Yeah, unless you will do.
Yeah, I feel like they add me.
But it's so, it
Quite
makes
hard.
it more fun.
You can do it tomorrow.
I know if you get, like, I know in, what helped me for lab and A&P was if they had a pelvis, and I didn't.
You know, I wrote all the treatments down. All the for both classes. already. Just like,
Yeah,
you know,
no.
you just take care of it.
He was fine.
He was fine, and then we took him to White House.
I'm just glad we don't have, like, in practicum, like, case studies, I'm glad we don't have to spell it.
Yeah, I'll
Because
never
I
do
saw a
that
lot of
again.
things.
It's a lot. And then I got physics. I've been big. So that's how
I
much
It
class.
just sounded out.
Sorry.
Yeah.
I love Star's Animal Clinic. The doctor is amazing.
I will probably, I bet this
On
will,
the main Broadway.
this will probably be
Down
online.
by,
But, oh, sorry. Now.
Bucks.
I like that.
It's like kind of diagonal from there.
We haven't went over this.
So
Pelvis.
recording, he likes to all the time in meetings.
This is you.
in the room with him.
Oh.
They cut off the-
I was like-
I saw that too. I was like, what?
they took
That's
care of
awkward.
everything, got it created for me. Then a month later, they sent us a card, said,
No.
thanking you, and everybody wrote
I
on
like
it.
that.
I cried all over him. I was like, thanks.
No,
He was my baby.
the test, yeah.
I wanted to,
Well, it's not your
we paid
average one.
$375 for him.
Probably makes you
Here
better.
in Texas, they're going for like $1,000. I'm like, I don't think I paid $1,000 for a dog.
That is so
Especially when there's a lot of.
awesome.
Yeah.
No, I think to my grade, but
Like, not all some patients don't wear anything.
I'm doing fine.
Yes.
Doing fine.
You're like, I'm not right away. I need you to do this.
The only
Oh,
one.
this is.
Yeah, after clinic, there's this older lady, so she was doing something where we had to go this way, then go this way. And they told her, like, she's wrong to your side, she's like, I'm wrong to your, I'm wrong to my side.
I'm thinking that's a little better for me. I think I got one yesterday.
Did you?
Just come up with that.
Yeah, it's the way she's sad, so like,
I just wanna have an extra zone. I don't know, I've never had an extra zone. Cause like this one, like if I have for my knee to be straight, then like I just want, I had to have a brace on my little, but it didn't work. And I'm flat-footed. I didn't want to see it. I was like, I don't even care if I'm supposed to look. I just want to see. How many times have you seen Joe so far? What'd you say?
How many times have you seen him?
I love dogs.
Joe?
Oh, for this,
For physics.
just for chapter 4? Or?
Yeah, chapter 4.
I saw him 3 times last week, and then I'm gonna see him
So,
Monday, Tuesday,
like,
Wednesday, and Thursday.
Y'all have only got into part 2 on 3 visits?
Huh?
Y'all have only got into part 2 on 3 visits?
We haven't even got to part 2 yet.
Only the first time.
Cause like it's like taking me a while to like comprehend it because it's just so hard for me to understand this chapter for some reason.
I meet with him later today, but I've only gotten, I met with him last week,
I saw the second time around.
and
But she got me on this.
I've only gotten to,
Yeah. Okay.
I don't know if I'll be able to get done.
Cause last night I filled out the rest by myself.
Did you?
Yeah, because I was just like, I just want to review that chapter today and then go over the next one.
Oh my gosh.
Yeah, I was gonna say, aren't you?
Nathan, I have a question.
Shoot.
And it's not about positioning, it's about physics. On the first video, you said, which I wrote it down, but you said, that, you know, the 2 poles in the magnet, you said it ran from the south to the north, but on the second video, you said it runs from the north to the south, so I'm just gonna clarify that with you.
It doesn't really matter, but I'm trying to picture it. It runs out of the south end into the north. No.
Cause in the book, it has it from the north to the south.
Yeah, it runs, yeah, because if you were to take a compass to the North Pole, it'd point to the sky, so it comes out of the north end into the south.
What's your name?
Okay.
Yeah. But it doesn't. The only way that it doesn't matter in that, we're not gonna test on that, but the only way that the only reason I point that out is because on Wednesday, what we're gonna talk about is that we're gonna use alternating current, right? The reason that the transformers have to have alternating current is because alternating current sets up a changing magnetic field. Since the current's going in and coming out and going in and coming out, what that's doing is creating a magnetic field in one coil of wire. But in making it come in and out and in and out, that magnetic field shifts from North Pole here, South Pole here, to North North Pole here, South Pole here. So it's almost as if you're taking a magnet and you're spinning it around and around and around. So that whenever we take a secondary coil and put it up next to it, the requirement for creating electricity with a magnet is to have a changing magnetic field, right? So by using the alternating current, we create that changing magnetic field, and then if we put a secondary coil next to it, then we create current in that secondary coil. Whereas if it didn't change, the magnetic field wouldn't change, and since the magnetic field doesn't change, we couldn't create current in the second coil. So which way it goes doesn't really matter. It's just for that purpose. I'm not going to ask you which end the magnetic field comes out of, or which end it goes into. The point of reference is just so that you understand that it changes, right? Because theoretically, how do we know the north end of the magnet is not the south end of the magnet, and vice versa? How do we know that north is truly north and not south? Yeah, it's just a label we put on it. So, all right. So, anatomy of the pelvis. You're going to run into some questions sooner or later that talk about the innominate bones. And the innominate bones are just your iliac bones. It's just a different word for the same bones. And sometimes you'll hear it referred to the not really the pelvic girdle, but the sacrum attached to the hip bones as being the innominate bone, the entire thing just being one single bone. So it really consists of 4 bones. The innominate bones, the left and right innominate bones are all of the bones of the pelvis proper attached to the sacrum and the coccyx. So we're going to talk about the innominate bones, the individual pieces of them, because there's 3 bones that make those up too, and the sacrum and the coccyx itself. So it's the base of the trunk and a girdle for the attachment of the lower limbs, and a protection for those organ systems in the lower pelvic cavity. So pelvic girdle proper, what we've got are 2 hip bones, they're referred to as the os coxae or the innominate bones, but there are 3 bones that make those up. So the ilium, the ischium, and the pubis. So the ischium and the pubis form what we call the anterior pelvic bones, and it's the lower portion down here, right? So we call this thing right here where these two come together the symphysis pubis. The ischium and the ischiotuberosities are what you actually sit on. We hear the tailbone, you sit on your tailbone. Your tailbone is kind of this thing back here, which is the coccyx. Whereas your ischiotuberosities are what you actually sit on. Those are your butt bones right there. Okay? So the hip bones, ilium, ischium, and the pubic bones. And they all join together. You probably can't see it, but they all join together in the acetabulum. All 3 of them form a portion of the socket portion of the ball and socket joint. Okay? So the ilium is the biggest of the 3, and it consists of the body and broad curved portion is sometimes referred to as the ala. And it forms a superior 2/5, so the bulk of it, the acetabulum, is formed by the ilium. So it's got 4 prominent processes, and you kind of work your way through these. You got anterior, superior, iliac spine, so you got 2 differentiating terms there. Anterior, so it sticks out the front. Superior, above something else, right? So if you've got that, then naturally what you're going to have is an anterior, that one's superior, so you've got a inferior iliac spine. Don't really have an acronym for that, and we don't really talk about it a whole lot. But you've also got a posterior superior iliac spine, and therefore you're going to have a posterior inferior iliac spine. So the top uppermost portion is what you're most familiar with, and that will be your iliac crest. So you've got superior, inferior, superior, inferior. And a sciatic notch is what we refer to that big hunk of bone that's missing in the posterior portion. So the ischium consists of body and the ischial ramus. The body forms posterior 2/5 of the acetabulum, and the ischium, ischial ramus joins together with the inferior ramus of the pubic bone. So again, the ischial tuberosity is where you sit. Ischial spine is located on the upper posterior portion of the body, and a lesser sciatic notch is the indentation just below the ischial spine. Pubic bone consists of a body, a superior ramus, inferior ramus. You're not going to have to label all this stuff, but the pubic bones and the ischium bones form what we call the obturator foramen, and the obturator foramen are these two holes right here in the anterior pelvic bones. These are going to be good indicators of whether or not we've got fracture. You're going to look at the anterior pelvic bones. Anytime we've got a bone that's got a great curvature in it, like these bones, or the mandible, any kind of bone that's got a really steep curvature to it, it ain't going to break in just one place. It's going to break in multiple places. So it's kind of like taking a pretzel. You know, if you were to try to break a portion off of the pretzel, where's it going to break? It's going to break in two different places. You can't just snap it in one place. You got to snap it in two separate places. So pelvic bones, that's what's going to happen. So this structure here, if it's going to break, it's going to break in two different places. If we break the ilium, theoretically we could have a fracture here and then a separation of the anterior pelvic bones at the symphysis pubis. But in a lot of cases, even ilial fractures are going to be associated with that anterior pelvic bone fractures. So imaging these anterior pelvic bones is going to be kind of difficult because they're at an angle. They're really at two angles to the image receptor and central right. So we'll get there here in a bit. Obturator foramen. So that's what it all looks like from the anterior aspect. And from the lateral aspect is the acetabulum. So the femur we already talked about. We're not going to run back through all that. You know the greater trochanter, the lesser trochanter. You know where the head is and the neck is. You know the intertrochanteric line, all the applicable parts to it. So the joints in the pelvis, we've got the hip joint. You know we have a tendency to think of the iliac crest as being our hip, and really our hip is a joint. The hip joint is the ball and socket joint, the head of the femur, and the acetabulum. So that's our major articulation, but you've also got articulations at the spine at what we call the sacroiliac joints. So this is the iliac bone, and that's the sacrum. So the joint in between them is a fibrous joint. It doesn't move a whole lot, but it is the sacroiliac joint, the SI joint. And the symphysis pubis, we already talked about, that's where the two anterior sets of anterior pelvic bones come together. And it's slightly movable, and I think we talked about this when we were talking about the anatomy. It does separate slightly during childbirth to open up the birth canal a little bit and give a little bit of room there. Sometimes though, we'll have fractures in the pelvic bones, I mentioned that a minute ago, that will open that up significantly. So you may have a huge gap in between your anterior pelvic bones. So there's differences in the anatomy, the appearance of the anatomy. And this is really, you know, one of the foundations for forensic medicine. If they find a skeleton somewhere, they can differentiate between whether it's male or female by looking in part at the pelvis. So in males, the pelvis is heavier and it's more narrow. The hips are more narrow. And you know, you look at athletic people who don't have, you know, not carrying around a few extra pounds, and you can kind of see this. Males' hips tend to be much more narrow, and the angle at the symphysis pubis you can't see, but it's more acute. or acute, meaning it's more like at a 45-degree angle, it's like that. Female pelvis, the anterior pelvic bones where they come together is more broad, okay? So what I'm talking about is this angulation right here indicates to me that's a male. Got a pretty steep angulation. If it was female, it'd be coming off at an angle more like that. Okay. So we talked about all those, or some of those anyway. You know what the iliac crest is, you know what the ASIS is, you know where the symphysis pubis is, greater trochanter, ischial tuberosity, tip of the coccyx is at the very apex of that bottom bone. What I pointed out before was what some people refer to as tailbone. All right, so in hip localization, this is where it starts. I said they kind of get complicated in textbook, and they do. Really, all you got to do to find a hip is go just below the ASIS, and you're going to find it. But they've got a number of steps you need to memorize, or at least be able to recognize on a test all the way through the registry. So, highest point of the greater trochanter lies in the same plane as the hip joint and the coccyx. So you can find the hip joint and the coccyx just by finding the greater trochanter. It's on the same horizontal lateral plane. So the most prominent point of the greater trochanter is the same plane as the symphysis pubis. So if you can get the patient to internally and externally rotate their foot so that you can find the greater trochanter, the very top of the greater trochanter is going to be the same plane at the same level as the symphysis pubis. So, you know, if you need to localize the greater trochanter, you couldn't feel the greater trochanter because the patient was hypersthenic and they've got a lot of hip, right? They got a lot of soft tissue there. Then you could theoretically palpate the symphysis pubis, or really, really, really don't recommend that you do that. So you can palpate the ASIS and the superior margin of the symphysis pubis, and you could find the greater trochanter if you were so inclined to do so. I've had, I don't know if I've told you all this or not, but I've had female techs that routinely palpated the symphysis pubis for KUB, and I've had them on some male patients. You know, the patient didn't know what they were going to be doing, and you know, they palpated the symphysis pubis for their scout view, and then let's say they were doing an IVP, which y'all probably haven't seen, might not have seen. Anybody seen an IVP? No. It's a study of the kidneys where we put contrast in the patient, so we shoot multiple views over and over again. So for whatever reason, you know, this one stands out, but for whatever reason, we were doing an IVP on a probably a 14-year-old boy, right? And she shot the KUB scout, and she came back in to readjust, and he had readjusted himself so he would get felt, you know. So I really just don't recommend that you get in the habit of palpating the ASI or the symphysis pubis, because something like that could happen, and nobody wants that. Aside possibly from a 14-year-old boy, apparently. So I don't recommend that. I don't recommend you palpate anybody's symphysis pubis. You'll see some people do it, but that's my official position on it, is there are other ways to get around it. So what they're saying is that you palpate the ASIS and the symphysis pubis, then you draw visually an imaginary line that connects the two. And then you can find the anatomy that you want by drawing another line perpendicular to that line. And what you're going to find is that 1.5 inches down that line, you're going to find the femoral head. 2.5 inches down that line, you'll find the femoral neck. That's a lot of steps, right? That's a lot of steps to go to just to find where the anatomy is going to be, when the anatomy is going to be directly below the ASIS. Top of the film at the ASIS, longitudinal line running straight down from the ASIS, you should be able to find the femur. Or top of the collimated field, let's say. since y'all are all using the same size image receptor, top of the collimated field, adjust your collimated field to 10 by 12. Put the top of that collimated field at the ASIS and run that line of collimation straight down the finger. You should find it. Top of the collimated field here, and then that line going straight up and down. And you're gonna hit it every time. And you don't have to go poking around on, symphysis pubis and doing any kind of mental calculations, anything like that, okay? Also, if you do that, you put that line right there, then you don't even have to use 10 by 12, you can use more like, 8 by 12. Collimate a little bit more. And that's what that says. All right, so whenever we're taking images, we want to remove any heavy elastic. You want to get it off the patient if at all possible. Obviously, if they've got a broken hip, you're not going to really undress the patient, and it really kind of becomes moot. But if you got a walkie-talkie type patient, just go ahead and tell them to take everything off, put a gown on. Then make sure that you cover the patient up too, as well. So if you got an ambulatory patient, it's just going to be supine on the table. If they're non-ambulatory, you may have to leave them on the backboard. You may have to shoot them on the stretcher, which becomes a problem because if you're shooting a hip on a full-grown person, you're going to need not only the image receptor, but you're going to need a grid as well. Now, the problem becomes if you're taking a hip on a bed, then what you may have is once you get the image receptor under the patient, it may tilt a little bit. Have y'all been through grids at all, really? And construction of grid and how it works? Anybody? No? Okay. What a grid is it looks like a thin little box, and what you've got in it are pieces of lead that are standing on end. So they're little bitty strips of lead that are standing upright like that. And the purpose for a grid is that whenever you create scatter radiation inside of the patient, the scatter goes off at funny angles, right? So if you've got lead and the X-ray beam is perpendicular, or it'd be perpendicular to the image receptor, but parallel to those grid strips, it'll go through and everything's good, right? So can you see the light through there? Yeah. But if my scatter radiation is going at an angle to those, then what that's equivalent to is it trying to go through there. Can you see the light through that? No, so it absorbs the scatter radiation. The problem with a grid is that if you've got any kind of an angulation on a grid, and it's not an angulation that goes this way in relationship to the grid strips, but it's going at an angle this way, then even your good X-rays are going to be absorbed. That's what we call grid cutoff, okay? So you got all these things standing up like that, and if your grid's tilted because you're in a soft bed, then you're going to have grid cutoff and you're not going to get an image, okay? So that's a problem with grid use, is that you got to be careful of that if you happen to be on tabletop. Or not on tabletop, but in the patient's bed. So radiation protection is going to be really kind of tough to provide radiation protection. You can provide it for areas of the anatomy that aren't going to be represented on the image receptor. It's just going to be very difficult to shield the gonads on a patient for a hip or a pelvis. You don't want to include shielding that would obstruct diagnosis. Just have the patient hold their breath. It doesn't have to be deep breath in and blow it out. Just tell them stop breathing and all that. So pelvis, AP of the pelvis. All we're going to do for AP of the pelvis is basically a low KUB. So have the patient lay flat on their back. They can elevate their knees if they want to, but don't elevate them much because we're also going to be looking at the hips as well. So really better to extend the knees, but if the patient can't, totally extend the knees, you might put a little roll under their knees just to relieve that back strain a little bit. So one unrotated, which means that our ASIS are going to be equidistant. They're going to be the same distance from the image receptor. You're going to medially rotate both feet 15 to 20 degrees so that we don't have that foreshortening of the femoral neck. Again, as provided the patient doesn't have a fracture, we want to internally rotate those 15 to 20 degrees. All right, that places the femoral neck parallel to the image receptor so they don't foreshorten. Top of the image receptor should be 1 to 1.5 inches above the iliac crest. And the central ray should be perpendicular to an area which would be right to the middle of the pelvis, which would be 2 inches inferior to the ASIS and 2 inches superior to the symphysis pubis. So if you got both of those things going on, 2 inches superior to the symphysis pubis equals 2 inches inferior to the ASIS, what does that tell you about the average distance from the ASIS to the symphysis pubis? It's about 4 inches, right? So when we get to exams where it calls for specifics 2 inches above the symphysis pubis, what can you do? Center 2 inches below the ASIS, right? Same thing. So we'll get to sacrum and coccyx, that will not be helpful. All right, so evidence of proper collimation, entire pelvis along with the proximal femur. Want both graded trochanters to be without foreshortening and with the ilia equidistant from the edge of the radiograph. So in the center of the image receptor. Lower vertebral column centered in the middle. No rotation of the pelvis. Rotation of the pelvis becomes immediately obvious. If we have no rotation at all, then our anterior pelvic bones and our obturator foramen look the same. And the peak, the apex of our coccyx is going to be right there at the symphysis pubis. Now, if I have any degree of rotation, watch what happens. The appearance of the anterior pelvic bones is totally different. Our sacrum and coccyx is going to be off-centered inside of the birth canal. What we'll get is what appears to be elongation of the iliac wing closest to the image receptor and foreshortening of the one furthest from the image receptor. See how that? So a lot of things to look for in rotation. Should look like that. So looking at the anterior pelvic bones, what would you say about this pelvis?
Female.
Female. Very good. All right. So the cleaves method, we got modified cleaves, we got original cleaves, and what most people are going to refer to this as is a frog leg. So we got unilateral cleaves, we got bilateral cleaves, and most people just refer it to a frog leg, either a bilateral frog leg or just a frog leg, the left hip or the right hip. And what we're going to do with this is we're going to start off with the patient as if we shot a pelvis, an AP of the pelvis. But in the true modified cleaves for bilateral hips, what we're going to do is we're going to bring both feet up. So you're going to bend both knees as far as the patient can, put the soles of their feet together, and externally rotate both of the femurs. So draw the feet up to about 45 degrees, put the soles of the feet together, externally rotate. There's a picture of the lady in the textbook, and you kind of see how that gets the name frog leg. So otherwise, we're going to position as if we are positioning for a pelvis. Some of your doctors, some of your orthopedic surgeons will actually want you to center a little bit lower so that possibly you get a little bit more of the femur there. But most of your radiologists, if they're just looking for the femoral necks, will just want you to center as if you were centering for a pelvis. Okay, so what it's gonna look like is that right there. Now notice, this patient looks like they've got a percutaneous pinning, probably had a neck fracture. But if this image ended right here, then what we would need is further confirmation that there's not a fracture below this prosthesis or this piece of hardware. Generally, if somebody has a piece of hardware in and then they have a fracture, the fracture is going to be just below that piece of hardware. So a patient's got plates and screws on their hip because they broke their hip. They fall again. The most stable portion of their anatomy at that point is their hip itself. So you got this hard plate, and just below it, you've just got this soft bone. And what's going to happen is that if a patient falls down, they're going to break right below it. So anytime a patient has any kind of hardware in, be it plates and screws or rod or whatever, we're going to have to see both ends of that, at least on one view. So again, some of your hospitals allow you to shoot an AP of the hip and a lateral of the knee if they have a rod in. Some of your hospitals are going to want to see AP and lateral of both all the way down. But you're going to have to see the end of the prosthesis to make sure that there's not a fracture there. And I would say even on this one, even though you do see the end of it, the patient still could have a fracture just below that. Not this patient, they did a frog leg pretty easily, so it would be an indication they don't have a fracture, but if the patient claimed that they couldn't move or they had significant pain, I'd want to see more of the femur there.
Have you done a lot of frog legs?
Unilateral, not a whole lot of bilateral frog legs. But the unilateral, yeah, and it's much easier to shoot these than what we'll describe here in a minute, which is a surgical lateral. The Denelius Miller, if a patient has a fracture, that's what you're gonna have to shoot. It's an ugly x-ray, it really is, but if the patient can't do that, then that's what you've gotta do. Okay, so I wanna back up just a little bit. Alright, so this is the same positioning I was talking about before. What I'd recommend that you do, if you're going to shoot a unilateral frog leg, is that shoot the AP first, because once you get into a unilateral frog leg, what you're going to do is, if you're only interested in one hip, is you may bend that one leg up and externally rotate. You may rotate the patient just a little bit, but if your centering was here and you externally rotate, it's going to put your centering a little bit lateral to where your hip is. All right? So what I'd recommend that you do is shoot your AP first before you try to shoot the frog leg, and just keep your positioning of your central ray really in the same place, and then take the collimator housing and turn it just a little bit, so that you maintain that same positioning where the ASIS was. Does that make sense? All right. So individual hip. We've kind of done this to death. Positioning for a hip and positioning for a femur fundamentally is just collimation, really. Central ray location collimation. For the femur, the mid shaft of the femur, or as much of the femur as you can get about after you get the image receptor at the top of the hip. For the femur, for the hip itself, you're down to a 10 by 12 instead of a 14 by 17 image receptor. So medially rotate the lower extremity 15-20 degrees. Place the femoral next parallel to the image receptor. Everything about that we've already done. So what it should look like is that right there. So ASIS would be right about there. And again, if the patient had a previous hip nail and they've got some hardware in there, you would need a larger image receptor to make sure you see the bone. Okay. So unilateral frog leg, we just kind of talked about that as well. So we're not going to do that again. The Hickey method, we're not gonna cover. That's just ugly. But the Donnellius Miller, we are going to. So, Donnellius Miller, also called the surgical lateral, is cross table, and it's what we use whenever the patient has a fracture, because the patient can't assume a frog leg. So, again, evaluate your patient. If the foot is externally rotated all the way to the side, then you're not gonna do a frog leg. You're not even gonna do a true AP. You're gonna shoot the hip as it is, and then you're gonna do this for the lateral. So what you're gonna do is you're gonna flex the knee of the unaffected limb to place the thighs vertical as possible. So you're gonna raise so we're shooting for the left leg. You're gonna raise the right leg up until the thigh is vertical or perpendicular to the table. You're gonna have to put it on something. Don't use the X-ray tube. You put it on the X-ray tube, and you're gonna move the X-ray tube around. Okay, so you're gonna misplace the X-ray tube. You're gonna miss the image. So find something to set it on. Sometimes another tech is gonna be in the room, and they're just gonna want to hold it up. You shouldn't do that, but you know, some people will. So you don't want any kind of rotation of the pelvis. So make sure that the rotation of the pelvis or the ASIS are equidistant from the tabletop. It says, unless contraindicated, rotate the affected limb 15 to 20 degrees. That would be only if two things. One, the patient probably does not have a fracture, rather. And two, that on the AP, you internally rotated the hip as well. If you didn't internally rotate the hip for the AP, then there's no need to internally rotate it for the surgical lateral. All right? So most of the time that's going to be contraindicated because your patient's going to have a broken hip. That's the reason you're doing this. Some hospitals will shoot the surgical lateral rather than the frog leg on a routine basis. So in some cases it applies, but most of the time it's not going to apply. All right, so the image receptor has got to be vertical, and this gets kind of confusing seemingly. So image receptor. What you're going to do is you're going to take the image receptor, the patient's laying flat on their back, like so, and the image receptor is going to be vertical, like this, not vertical like that, but vertical like this, and it should parallel the neck of the femur. So you got to use a little bit of imagination, try to figure out what the neck of the femur should look like, and you're going to put the top of the image receptor above the crest. So it's really kind of got to go into the patient's side a little bit. Some techs will feel for the bottom of the ribs and go just below that. That's fine. Either one works, but it's got to go above the crest, definitely. It's got to be vertical, and you want it to be as parallel to the natural lay of the neck of the femur. So about like that, about a 45-degree angle. Okay, and the central ray is going to be horizontal. I need a tall table. So, again, image receptor mashed in right above the patient's iliac crest. So iliac crest is here. Your central ray is going to be coming up in between the patient's legs from the opposite side and perpendicular to both the femoral neck and the image receptor. Okay? So, there we go. So, central ray should be perpendicular to both of those. Okay? So it's hard to envision. Right? But what you're going to see is that. Right? Now, some of your textbooks, Merrill's is not included, and I'm not real sure why, but some of your textbooks will say that instead of just elevating the hip in this step right here, elevating the unaffected leg to vertical. It'll say elevated but externally rotated. What that does is it takes the soft tissue on the opposite side and it rotates it out of the way. That cheek gets out of the way a little bit, right? So you have less soft tissue just over this area right here. So that's what you see right there. And if the patient's got a femoral neck fracture or intertrochanteric fracture, you might just see it. So Judet views. Judet views are technically views just for the acetabulum itself. And they're typically, and this is traditional, I'm going to tell you what Tyler docs like here in a minute. But what it is basically two views to show an AP and a lateral view of one acetabulum, okay? So what we're going to do on Judets are bilateral obliques, so that in one oblique, and it's going to show us the AP of the elevated side, okay? So what we're going to do is we're going to do two views of both acetabulum. So if I'm rotated towards my left side, I'm going to see an open acetabulum on my right side. We're going to see the AP on the elevated side. The lateral is going to be on the side closest to the image receptor. Okay? So rotating both directions. Okay? 10 by 12 image receptor just to see the acetabulum. Tyler doctors don't like to see that. What they want to see is a full pelvis, so a 14 by 17 image receptor. And they'll use the Judets, and what they'll see with one oblique is they'll see open acetabulum, right? We'll see open obturator foramen, so that these anterior pelvic bones become as perpendicular to the central ray and as parallel to the image receptor as possible. So if you've got fractures in the anterior pelvic bones, you can see those. You get an AP view of the downside ilium. You get a lateral view of the upside ilium. So if you've got fractures in any of those, you can see them. You can see basically a lateral view of the downside anterior pelvic bones. So in two views, what we're going to see in one view is we're going to see a lateral of the acetabulum, lateral of the anterior pelvic bones, AP of the acetabulum, AP of the anterior pelvic bones, AP of the ilium, lateral of the ilium, one view. Reverse that to a 45-degree oblique on the opposite side, and we see the reverse of all that. Two views, 45-degree oblique, show you everything in the pelvis, any possible fractures in the pelvis. Or how our radiologists like to see the Judets. Both 45-degree obliques positioned just like a pelvis, only with 45-degree oblique. Okay. That's what all that says. So unilateral Judet just for the acetabulum, one's going to look like that, one's going to look like that. That's what they're going to look like whenever they're shot as a full pelvis. Common hip fractures, you got the intertrochanteric fracture and femoral neck fractures, like what we talked about before. You got anterior pelvic bone fractures that can extend into the acetabulum. You got pelvic wing fractures. They can just be nasty. Pelvic wing fractures, whenever we have a fracture in the pelvic wing, in a lot of cases we'll get a lot of sharp little edges on it, and you've got major arteries. You got internal and external iliac arteries running through there, and they very well may puncture some of those. So very nasty fractures. Also, the bladder, ruptured bladder is not uncommon whenever we have pelvic fractures. We have hip fracture there, just different types of pelvic fractures. So, any questions?
Are you gonna post this video today?
Yeah.